Now I think we're moving to Dr. Anas Anbari. Dr. Anas is a consultant cornea and anterior segment surgeon. He is born and trained in UK. He got his fellowship from Moorfields Eye Hospital, and he practiced in several places in UK, and he moved recently to Kuwait. And he is well known for his support to ophthalmic education, especially in the Middle East. We're honored to have you with us, Dr. Anas. And
thank you very much indeed.
Proceed with your DALK, Big Bubble DALK talk.
Thank you. Trying to share the screen. Can you see my screen?
Yeah, we can.
Perfect. So I'd like to thank Dr. Nasir Akkad, Moria, and Amico for organizing this course and for inviting me among this distinguished faculty. I use Moria instruments, but I have no financial interest. Dr. Lamis, Dr. Agrawal, and Professor Liu talked about lamellar keratoplasty. Dr. Lamis and me will do the same. Just because penetrating keratoplasty is good, but not good enough. Penetrating keratoplasty has been the mainstay prior to DALK. It started more than a century ago by Edward Zerm near Prague, that's 1905. He did bilateral penetrating keratoplasty for a guy who had Lyme in his eyes. Later on, Castroviejo did penetrating keratoplasty. You can see the bottom photo, and usually the patient was seen well afterwards. The graft survival of the first PK graft is 95% at 5 years. The rejection rate is 11 to 18%. The survival of the second graft between 50 to 70, for the third 30 to 40, and for the fourth 0 to 20. Now, what's the difference between a graft survival or graft failure and graft rejection? Graft failure means the failure of the endothelium cell layer, which is responsible for the pump mechanism that keeps the cornea clear and transparent. Failure of this layer will make the cornea edematous and hazy. Rejection, on the other hand, is then the immune-mediated response that causes damage to the endothelium that could result in secondary graft failure. So, rejection is a leading cause of secondary graft failure, and in majority of cases could occur in 6 to 8 months postoperatively, and could occur late, up to 31 years post-transplantation. One of the earliest findings for rejection is the circumlimbal injection, so the junior doctors should look for it. And the endothelial rejection in PK shows kertic precipitates. So if a patient has KPs, we need to document it carefully so we can notice any new one and know that there's a rejection episode. The other sign is Cododos's line, and we could have the diffuse endothelial rejection. Other complications for PK is the wound leak, endophthalmitis, the devastating choroidal hemorrhage, and ectasia, peripheral host rim thinning 2 decades post-PK. Now, you've seen the main concerns regarding PK, so the search has been launched 50 years ago for a surgical substitute to it with less rejection and failure, less complications, less emergent, shorter follow-up, and can be done in high-risk cases. Years ago, they had so many difficulties, resulting in poor vision due to interface opacification, high regular and irregular astigmatism. It was surgically challenging with steep learning curve, and it was taking a long time in the OT. With the advent of new ideas and improvement in surgical techniques and instrumentation, several techniques have been introduced. The air dissection by Chad Rostron, Arkila and Price, Big Bubble technique by Anwar, the optical recognition and viscoelastic dissection by Meles, and Dr. Lamy is going to talk about it in a minute. Dry dissection, Subota, hydrodissection, Sajita, and a combination. The DALK has several advantages. It targets the diseased part of the cornea, preserves the endothelium, which means less graft failure and less rejection because the endothelium is the main reason of graft rejection. It's a closed eye surgery and there's no major complications, unlike the PK. It avoids the high and continuous endothelial cell loss associated with PK. It can be done in high-risk cases, less follow-up visits, fast rehabilitation, and we can do refractive surgery post-operatively to manage astigmatism. Indications include corneal ectasia, keratoconus, keratoglobus, pellucid margin degeneration, and stromal dystrophies, granular and lattice. Scars post-infection, bacterial, viral, fungal, or parasitic. Now, how to do the big bubble technique. The first step is refining the cornea. The second is injecting air at the posterior 100 micron to achieve baring of Descemet membrane. That is, injecting the air at the posterior 100 micron. We achieve one of two types of bubbles. Big bubble type 1, where the air lies in front of Duer's layer, the pre-Descemet layer. We get this in 80% of the cases, and the bubble starts forming in the center, then spreads to the periphery. The size maximum is 8 millimeter, and it has a bursting pressure between 500 and 700 millimeter of mercury. It doesn't burst easily. The second type is big bubble 2, and the air lies behind Duer's layer and in front of Descemet membrane. You find this in 50% of the cases. The bubble starts forming in the periphery, going to the center. The size exceeds 8 millimeter and it bursts easily. This is a video of femtosecond laser assisted keratoplasty with big bubble. We mark the center, use the femtosecond, suction, use the laser. This is a mushroom. All right, and then we check the trephination and then use Fontana's cannula to inject the air. Note the big bubble, 8 millimeters. And then we debulk the cornea, the stroma, using a crescent knife. We have remain a little bit of stroma. Behind it is the air bubble. We slash into it, and then we inject Helon behind the residual stroma, and then start cutting it with the scissors. I always make sure to have my graft ready before I start the patient. Now, in DLK, however, I do that, but I do not strip Descemet and the endothelium from the graft before I make sure that I'm not going to convert. So we remove Descemet and the endothelium, we put the graft, mark it, and do the suturing. This is how the cornea looks like after the surgery. And there are many ways of cutting using the flak. When the companies planned for flak machines, they had theoretical advantages in mind, including stronger wound healing, earlier removal of sutures, earlier visual rehabilitation, and less astigmatism. However, evidence suggests that there's no long advantage for flak when compared with mechanical trepanation, and that astigmatism improves significantly in the first 6 months post-operative for flak, but the difference does not persist beyond 6 months post-op. Visual results were reported to be comparable to PK when baring of Descemet was achieved. There's less endothelial cell loss in DLK in comparison to PK, in Mellis technique in comparison to big bubble, in phaco on previous DLK in comparison to phaco on previous PK. The annual endothelial cell loss rate in normal adult human eye is between 0.6 and 0.7. In PK, it's up to 50% at 5 years, the surgical impact is high on endothelial cell loss, and it continues high, and even gets higher every year. And DLK is between 4 and 22% at 5 years, depending on the technique. As we said before, the optical recognition causes less endothelial cell loss. So the impact is small in comparison to PK, and afterwards there's a stable, minimal endothelial cell loss annually. I have a question for you. What is the age for the graft donor that provides the best post-operative success rate? Less than 2 years old, between 10 and 18, between 18 and 30, 30 to 45, 45 to 71. Let's leave this for a minute. We'll come back to it. The DLK showed high safety. It reduced the risk of expulsive choroidal hemorrhage, endophthalmitis, cataract, glaucoma, and cystoid macular edema. Complications include double anterior chamber, post microperforation, which could resolve by itself, or we might have large double AC, where we need to do rebubbling, where inject air in the AC, as mentioned by Professor Dieu in the OT or at the slit lamp. Other complications include blood at the interface, which is not a problem if it's not in the visual axis. This main membrane falls does not affect the visual outcome. We still have the epithelial rejection in DLK, subepithelial rejection, and stromal rejection. So need to keep an eye on it because it occurs more often than what you think. And it could lead to interface scarring. The ectasia and peripheral host rim thinning, 2D case, post-PK, can be managed by DLK, large DLK on PK, as you can see here. This was described by Shrestha and team. We go back to our question. So less than 2 years? No, because the corneal elasticity is pretty high. Now, between 10 and 71 have the same success ratio. Donor's age is not an important factor in most PK for endothelial disease. This concludes that DLK is indicated whenever the endothelium is normal. It targets the diseased tissue and causes less rejection. However, it has steep learning curve and longer surgical time. I'd like to thank you all and thank my mentor who inspired me and taught me a lot in cornea, Mr. Charleston. Thank you.